Okay. Okay, welcome Dr. Habib and Tracy Meisner, our speakers today. Our program is called Queasy, Constipated, and Never Hungry, Gastrointestinal Problems with Cancer Treatments. Dr. Habib, you want to introduce yourself?
Yes, hi. Hi, everyone. Glad to see some familiar faces. Thank you so much. Thanks, Alicia. My name is Hamza Habib. I'm a pain and palliative care doctor here at CINJ. And I've been here about 6 months now. And you guys have been wonderful. It's been wonderful taking care of the patients, and it's been wonderful working with the faculty and the other staff as well. So I'm primarily a pain and palliative care doctor. I'm an interventional pain trained at University of Utah and palliative medicine trained at University of Chicago. Previously, I've worked at Columbia University in New York City for about 5 years before I moved to Jersey. And I think this is going to be a very nice, very fun, easygoing presentation. I get a lot of questions, so I'm really excited about presenting it. It's going to be funny. It's going to be, I mean, feel free. If I'm talking, feel free to interrupt, ask questions, bother. I'll do the same to you guys. So, Tracy?
Hi, everyone. I'm so glad that you all signed up for this to join us. We're both so thrilled to have everyone here, and it's also great to see some familiar faces as well. My name is Tracy Meisner. I'm a dietitian for the breast, GU, heme, and BMT programs at the Rutgers Cancer Institute, where I've been very fortunate to work for the last 3 years. Prior to coming, I worked for 10 years as a pediatric brain injury dietitian at Children's Specialized Hospital right down the street. And is where I did my training. I am Rutgers through and through. I got my undergraduate training and did my internship through the university. So Rutgers will always have a special place in my heart. I'm very much looking forward to doing this presentation. And as Dr. Habib said, if at any point in time during our presentation you have questions, please don't hesitate to ask. I hope we have a lot of fun tonight, and I hope that everyone enjoys.
Wonderful. So listen, this is kind of a funky presentation because we're going to talk about barf, we're going to talk about being picky about eating, and we're going to talk about poop. So yeah, it's kind of a weird kind of a little presentation here. I don't know. I'm pretty sure my 4-year-old kids would enjoy talking about poop and barf and being picky eaters. All right. So next, please. So nausea, let's start with nausea, right? So nausea happens in a lot of patients, especially the care that we provide at CINJ being a cancer hospital. We almost see nausea in about 62% of patients. And this is not just cancer specific. We see this in CHF patients. We see this in patients with ESRD, renal disease, who are going to be close to being on dialysis, patients with AIDS. So this is something that happens very often. Why do we see this more often at CINJ? For a couple of reasons. People who get chemotherapy, I mean, nausea is a side effect, unfortunately. People who get tumors or cancers of the GI tract or the stomach or the colon or the lower GI tract, they sometimes can get a lot of nausea because of obstructive symptoms. So this almost becomes, I would say, the third most important thing that I treat at CINJ. And it's always good to come to a specialized center where there are specialists who do this or have experience in this. So let's move on to the next slide. So basically, things you may be asked. So this is important. So whenever a patient comes to me and says, Doc, I got nausea, I ask a couple of questions. The first thing that I ask is, when did it start? What did you eat, right? What did you do? Did you go around in a roller coaster and turns out that it is not the chemo, it's the roller coaster ride, right? So we ask a lot of questions about that. We ask what you ate yesterday, what you ate today. Did you see how much vomit did you have? How many times did you vomit? How many times did you see any blood in it? Did you not see blood in it? Did you see something else? Was there food in it? Was it green colored, right? How many times did it happen? Was it just one time nausea? So be ready that we are going to ask about all these icky questions. And yes, we are talking about an icky subject. So yeah, we're going to ask all these questions. And once you get a history as to what is causing it after we do an exam, basically we will say, okay, do this, do not do this, take this pill before food, after food. So this is what goes on inside the head when I get a question about nausea. For my patients, I mean, one of the biggest causes, like I said, is the chemotherapy, and the second one being is the GI tumors. The other things that cause a lot of nausea in my patients is sometimes patients who may have some medications like pain medications. A lot of my patients are on morphine and oxycodone and all these pills. They can cause a lot of nausea. So that's another thing that we do. And then sometimes we put patients on multiple medications for nausea, because when patients are nauseous, there are a couple of things that happen. First of all, they don't eat. And when you've got a cancer and you're not eating, it doesn't lead to a good outcome. So we really want our patients to eat. So nausea management is important from that aspect. The other reason why nausea management is important is because when people are nauseous, they feel icky, they feel horrible, they feel terrible. So they will be anxious, they will be, I mean, almost like in a hangry state. Remember those Snicker bars ads? That's exactly what I expect when I see a patient who's nauseous. They don't talk, they feel anxious, they feel depressed. So nausea management is very important, because when a patient does not eat, when a patient feels horrible while getting these treatments, I mean, the treatments at that point become counterproductive. So nausea management is super important when it comes to cancer management and cancer treatments. Next slide. So one of the things that we use very often, and you may have seen this all the time, hey, this person has nausea. Let's give him some Zofran, right? That's the easiest word. That probably is one of the most common words used in a chemotherapy suite. Yeah, add some Zofran to it. We'll do this, right? So basically, Zofran is a drug that was made in the mid-1990s, and it was specifically made for chemo-related nausea that happened with chemotherapy. And it works really well. And it also works really well for radiation-related nausea and post-operative nausea. Sometimes we also use it for pregnancy-related nausea. We don't see that at CINJ, but that's something that it is approved for. So this medication since then has had a couple of other cousins that have joined the family of nausea medications. We've got cranisetron, we've got medications like newer drugs like NK1 inhibitors, which are called fosaprepitant and aprepitant. So there are a lot of new drugs that have come in. The reasons why I think sometimes Zofran is not indicated is people think that it doesn't have side effects. Well, clearly it does. Some of the common things that we see when we give someone Zofran is, number one, they can get constipated. So that's a big one. The other thing is that sometimes it can cause issues with headaches. So that's an issue again. Another thing that happens is that in certain people, it can cause a lot of anxiety. It can cause more issues with a certain heart rhythm, which increases, and it can lead to having some, I mean, almost, I would say that heart goes into a rhythm which becomes very dangerous. So that is important. So whenever we give this medication, make sure that you tell your doctor, Doc, I've had constipation-related issues. Doc, you're giving me this drug. I get headaches. Doc, you're giving me this drug. I have a heart issue. So these are things that you should be asking. So this is important because there's a good chance anyone who's been at a cancer center, this is a drug that probably they've gotten one way or the other. All right, next slide, please. Other medications that we use. Remember when I said that we ask a lot of questions, and the questions that we ask are not just only for finding out what the cause of the nausea is, but also to treat and find the best drug that is available. So let's say I get a diabetic patient, right? A patient who has diabetes, high blood sugars. What happens is that sometimes when they eat, their food does not go down the stomach as fast. So if I get a complaint of nausea and the person says, well, you know, when I eat, I don't feel like my food goes down. I feel very gassy. The food sticks in my stomach for like 6 hours and I just feel nauseous all the time. So then the drug, the first thing that you see up there, we were trying to get this as a slideshow, but it didn't happen. But what you're seeing here is the first drug, the metoclopramide. I don't know if it's 17 words or 16 letters. So it's a big name. It's a mouthful. But that is something that we use. It makes the stomach get supercharged and get the food down faster. So in addition to nausea management, it does that too. Another medication that is similar to metoclopramide is called prochlorperazine. Again, I mean, I just feel like people send you to school just to learn these things. So this like horribly long name that I cannot even say correctly. I don't know why. But this guy is similar to the first one, which is metoclopramide. Together, they have all the letters of the alphabet. And basically, what is happening in this medication is that it helps the nausea, but it doesn't have the function of making the food go down faster. So a certain kind of nausea, let's say someone had something bad to eat or someone has stomach upset, these medications are decent. If someone has constipation, metoclopramide may work. And if someone just has nausea, then prochlorperazine, which is compazine for the easier term, is helpful. Let's say if you ever come to my clinic, anyone who's come to my clinic knows how much running around we do. It's almost like going in a merry-go-round, right? It's like we're going in circles around the nurses station. So let's say I decide to take 10 to 20 little swirls around the place, and I start getting nauseous. Or all of a sudden I decide I want to go into the parking lot and pin my car left and right all over the place, right? Go in circles. So basically, that nausea that you get, like I would say my kids get sometimes when they're in the car, that is because of the vestibular system. The ears, there's a little tube inside, and that gets messed up, and that gets unhappy about life, and that starts giving you nausea. So again, if you go on a merry-go-round, if you go on one of those rides at Disney World, those things, the kind of nausea that you get from those things, you would be better helped by an antihistamine, right? So remember when kids get nausea, we give them Benadryl. That's an antihistamine. So that is how that works. Third one is steroids. Now you would ask, why would you give steroid for nausea? That's just wrong. Steroids are something that people take to get all muscular and look like Arnold Schwarzenegger. So no, steroids sometimes are helpful for other things too. You don't just have to turn into Arnold Schwarzenegger from 1983. So the point that I'm making is sometimes the pressure in the head becomes too high because of a certain tumor. Tumors sometimes go to the head. We can use steroids. They can decrease the pressure in the head and help with the nausea. So that's a big thing what we use nausea medications like steroids for. Number 4 on the list is Dronabinol. Now, this is the thing that you will probably have the most questions for in the end, I'm pretty sure. This is a substance or a chemical that is extracted from cannabis. And this is basically the component of pot that helps you get a little high and also at the same time helps with nausea and helps with appetite. Now, you would say, why don't we just use pot, right? Why don't we just use this Dronabinol and all that, all this stuff? And why do we have to go through these other medications that I've just talked about? Well, the answer is because Dronabinol has not shown a lot of good data. So let's say someone comes to me with nausea while they're on chemotherapy or off chemotherapy or with drugs or something else or some surgery that they've had. The first thing that I usually try is things that don't make people high, things that don't have a lot of side effects, things with which people can drive and stay active and not fall. So I usually use Zofran or metoclopramide or prochlorperazine, the compazine, as the first line, and then I would add this as a fourth line drug. So I would say that anyone who asks me, why don't we use cannabis as the first line? It's because, first of all, it's not as efficacious at times. And secondly, it's got side effects that can cause more issues for patients. People, when they're on chemotherapy, their brain is already what they call as the chemo brain, right? You get chemo brain. And if you put Dronabinol or marijuana on it, it's just going to become more like a ganja syrup. So I don't want that. So that's why we don't use it as the first line. So the last thing on the slide is anxiety medications. I can tell you when I was a kid and we used to have an exam or a test, I always got nauseous. Up till 5th grade, I was always nauseous because these things provoke anxiety. So a lot of patients that come to our clinics, they're anxious. They're anxious, number one, for their test results. They're anxious for what treatments they're going to get. They're anxious for what kind of things would the doctor talk about? What kind of effects would chemotherapy have, knowing that last time when they got chemotherapy, it sucked, right? So we use anti-anxiety medications for these things, especially when people are coming for chemotherapy and they're nauseous. This is very helpful. Sometimes when people go for MRIs and CAT scans, they get anxious about, oh my God, I'm scared that my tumor will come back and the scare scan will show it, to calm them down a little bit. So these anxiety medications help a lot. So I would say under the circumstances, if someone is not eating and nauseous at the same time, marijuana supplements may be good. And if someone is just anxious before coming and on the day of chemotherapy, they get anxious and throw up before getting chemotherapy, then we can give them anti-anxiety medications and that can help too. Next slide, please. All right, so a couple of things. So one of the things that worked, I think it's number 8. Let's see if we can go down. Perfect, thank you. So I remember when I first joined my first cancer center, I was at University of Pittsburgh. And those guys were sticklers about not wearing any cologne. And imagine a doctor who's worked 24 hours. He doesn't smell like a bed of roses. I mean, he believe me, he doesn't smell good. But guess what? People with chemotherapy, people who are getting certain treatments, they can get nausea from certain smells. Especially colognes and perfumes can do that. So I used to tell my patients, listen, I've been in this hospital for the last 24 hours. If I smell like a bum right now, I mean, I'm sorry, but they won't let me wear a cologne. So avoid strong smells, avoid other triggers. Someone who's bringing you in for treatments that day, or you're going back, tell them, listen, I want to open up the windows. I want to get some fresh air. Another thing that we tell people before they come for chemo treatments or if they get nausea is frequent small meals. So frequent means, and this is something that Ms. Meisner will talk about, and she will go into this much more detail. But the idea is if you have less food in your stomach, there'll be a lesser chance that you will have things remaining in your stomach to throw up when you come for chemotherapy or after chemotherapy. So something light, something that is quickly absorbed. I don't want you to have a steak before you come in and have a Kobe beef steak. I mean, if you want to have a cup of coffee, have a cracker or a cookie or something, that's perfectly fine. All right. And the other thing is that a lot of people feel that, well, I'm throwing up so much stuff. I need to eat fast. I need to fill up really fast because I want to get stronger. Well, guess what? If you're about to throw up and you take stuff inside and eat it, you're going to throw up more. So don't do that. So limit oral intake during severe episodes. Next slide, please.
Hey, Doc, I've got a question.
Mm-hmm.
How do you feel about fasting during chemo? There is some evidence in the literature that says extended fasts of, as much as 120 hours can be a positive effect on this side effect.
No, Mr. Khan, that's a great question. So the answer is yes, there is some data that has come out which has shown that fasting as a strategy for chemotherapy is great. Again, goes back to the same point that if you have things in your stomach, you will throw up that stuff, right? There's a greater chance of that coming up. But now then you have to measure, kind of do the pro and con ratio. Let's say if there's a certain patient who's already very weak and you put them on glucose fasting and they don't have food, they'll get weaker. They'll end up being dehydrated or get other things. So that becomes a concern. The other thing is that sometimes what happens is that when you come for chemotherapy and treatment, sometimes you get oral pills as well. And those oral pills can sometimes cause a lot of acidity in the stomach as well. So I usually like to say that yes, fasting is okay, maybe 12 hours max 12 hours fasting, because in 6 hours, most of the foods go down into a place where it's hard to throw them up. But that being said, a shorter, smaller meal, let's say a couple of hours before, may just, right? So that may just work well. All right. So,
hey, Judy, this is Leslie. I'm sorry I missed your call. I'm on a webinar, so I didn't see that the phone was vibrating. Call me back. I'm on a webinar, but I don't need to know what he's saying.
That's good feedback.
That's so funny.
So
That is feedback. I have no idea. That's at least honest.
So if I understand you correctly, it's really a sort of pros and cons trade-off, a function of the status of the patient.
That is correct. That is correct. You have to see what works best for what patient. I would say if there's a patient who's getting a standard chemotherapy with which that person gets very nauseous, but has a reserve where he or she can function, that is great. But at the same time, I would say that if there's a patient who's losing weight, who's not doing well, who gets more nauseous when their stomach is empty, I can tell you when my stomach is empty and I'm driving the car, I start getting nauseous. So it may be not the greatest plan. So I would say we have to tailor it according to their needs. But there's one study, I know which study you're talking about, and actually it has gained some momentum recently.
Yeah.
You're right, Mr. Khan, that's true. Good, great question, by the way, excellent question. All right, and listen guys, I would say that if you have questions like Mr. Khan, feel free to interrupt me. We got a lot of time and we're just chilling. This is a good little party that we got here, right? So basically, one of the things that we see sometimes is refractory nausea. What that means is that people are just throwing up. Whatever you do, you don't feed them, they throw up. You don't give them anything, they still throw up. You don't give them chemotherapy, they still throw up. It's like, what is wrong with them, right? They're just throwing up continuously without any rhyme or reason. It's just persistent nausea, they're not eating. So one of the things that we do for these patients is we give them around the clock medications under these circumstances. Remember the huge list that I showed you initially, the 4 big medications, including the marijuana thing? So what I do is that I use all of these medications and see which one works best for them, or just put them on it so that in a little while their nausea reflex stops, right? And let's say if it stops, that's great. And once things start getting better, we can slowly take them off those 2 or 3 medications that we've put them around the clock on. But let's say someone starts getting dehydrated, someone starts getting delirious, someone starts getting so tired and fatigued that they're unable to get off their bed, or someone's sugar goes down, or blood glucose level, or someone's, blood pressure starts going down. That is a warning sign. Now, these are things that are important. When you see them in your loved one or yourself, if you notice them, that is the time when you call 911, or in a better state, have someone take you to the emergency room, because those are circumstances when you cannot keep things down. Those are circumstances that things can get dangerous, and you want to be in.
Dr. Habib, I muted you by accident. I'm sorry.
So one of the things that we can do is when people have this uncontrolled nausea, we want them to come to the ER. We want them to come in and get, number one, blood tests to make sure whenever you throw up, you'll see that your oncologist will say the same thing. Get a blood test, see what your sodium is. Let's see what your potassium is. And if they're high, or if they're low, or if your kidney numbers are not good, you need some hydration. So that is something that you get in the chemo suites as well, infusion centers. So do come for these warning signs. They are important. And let's say once you come into the hospital, the things that happen, unfortunately, most people know, is that you will get an IV line. They'll draw some blood, get some numbers out real fast, and they will give you IV fluids as well. And those fluids will kind of like perk you up and make you feel better till you are able to eat and get some energy by yourself. They can put some glucose in there as well, so you get some energy too. So that is usually the goal. They'll give you some IV medications, because if someone is throwing up like repeatedly over and over, sometimes even if you give them the nausea pill, it's not going to get absorbed. You need to get them in so that they can get their IV line and get the medications through IV so they can be absorbed. All right. All right, so we are up to slide number 9. Ask me questions.
Does anybody have any questions so far? You can unmute yourself or you can add them in the chat.
If no one has questions, then I'm going to start asking questions. And I'm going to start giving you grades for those questions.
Yes, I have a question. My wife is on a liquid diet. She doesn't eat anything. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes when she throws up, she has to use a diet. And sometimes I give her Ondin, that OND
Mm-hmm.
medicine. Should she get
Mm-hmm.
that before she starts the Osmolite 1.2 or afterwards, or how should I give her that? I mean, she hasn't thrown up in a while, but for a while she was throwing up, and I was giving it to her right before I gave her the Osmolite 1.2.
So I have a question for you, Alan. Who's your wife's oncologist?
Dr. Eisner, and it was the one of the dietitians at the Cancer Institute that gave her the the Osmolite 1.2 regimen.
So that's a very good question, Alan. I'm really happy that you asked this question. So the question that Alan has asked is that when we have someone who's getting nutrition through a tube, or nutrition that is liquid, or nutrition that is causing nausea, should we give nausea medication before we give them that solution or that dietary supplement? And the answer, Alan, is yes. In most cases, if there is no contraindication, it is okay if you feel that this person today is going to throw up, right? You can give a nausea medication, let's say about 45 minutes before, right? And see if their nausea gets better, and then feed them. Filling up someone's stomach when they're already nauseous can be counterproductive for two reasons. Number one, I mean, the food's going to be thrown up. And the problem is when people throw up, especially the reason why I asked if it's a patient of a certain doctor, Dr. Eisner is a lung doctor and an upper and a thoracic doctor and an esophageal doctor. So he treats those kind of cancers. So the problem is sometimes the food can be aspirated. It can go in the wrong windpipe, and that can cause problems. So Evan, your question, the answer is, if you think that giving that a little dose on a certain day, not every day, I would say, on a certain day when you know that she's getting nauseous and you're starting to see those things, give that give a little Zofran. It's not a bad idea. The ondansetron. Good question.
Do you know if that can be crushed and put through the feeding tube as well, or does it have to be swallowed, that pill?
If it's a pill, it can be crushed. If it's a capsule, well, then you got a problem on your hand.
Yeah, it's a pill, so it can be crushed and put in with the. Okay.
Yes.
Thank you.
Yes. Yeah. Crush it real well, right? Of course, I'm going to send you a bill now. I'm just kidding. Good question.
Dr. Habib, there's a couple other questions in the chat. Do you want me to ask them and you can answer?
Yes, please. Thank you.
Sure. What could be factors that increase the risk of nausea and vomiting with chemo?
So the risk factors that can increase is, number one, there are certain kinds of chemos that can cause a lot of nausea. If you hear that someone is getting carboplatin or cisplatin or one of those Taxol or some of those platinum-based medications, sometimes people get oxaliplatin and all those things. They can cause a lot of nausea. So always ask the doctor, Doc, you're giving me or my wife or my loved one this medication. Would it cause nausea? Right? That's a good question. The other thing is, Alicia, there was a second part to that question.
What could be the factors that increase the risk of nausea and vomiting with chemo?
Exactly. Another thing that we've already talked about is coming with a full stomach like crazy and then getting chemo. That will increase the risk. If someone has already had nausea and vomiting in the past with a certain chemo, or if they're anxious, or if they're worried, or if they've got a certain GI tumor that causes obstruction, yes, that can cause a lot of nausea and vomiting. No, definitely. That's a great question.
Okay, here's another question. Is it true that people who enjoy too much alcohol do not have any issues with nausea and vomiting when they get chemo?
So let me clarify that statement. Good question. So let's say if someone drinks a lot of alcohol, right? And do they share or not? If they don't share, that's a problem. All right. But the idea is if someone has a lot of nausea, I mean, the issue is that alcohol sometimes when consumed in excessive amounts can cause nausea by itself. So the answer would be that anyone who gets a certain medication, alcohol should not have to play a role in decreasing the nausea. But if consumed with chemotherapy, yes, it can make you throw up for a couple of days. So yeah, don't drink and chemo. Don't drink and drive. Don't drink and chemo. All right. That's not going to be fun for you or your family to clean up after you. But that's a good question. Is that what the question was? I mean, the person who asked, feel free to get on the mic and ask in person.
Yes, they asked me to ask it for you, to
I
you.
see.
Yes.
Okay.
And that's
So,
all
yeah.
the questions for now. Yep.
Good. All right. So let's move on to the next slide. Let's talk about eating. That's my favorite topic. Next one, please. Okay, so anytime I get a patient and they're not eating, I mean, and this happens more often in cancer settings than otherwise. So they always use two terms: anorexia. Oh, this person is anorexic. This person's got anorexia. So let's talk about anorexia then. Anorexia is the actual loss of appetite. Or if someone looks at food and they're like, "Blah, I don't like it," that's anorexia. All right. It's something that we see in a lot of psychiatric patients as well, patients who've got other issues. But in cancer patients, we see this unfortunately because the part of the brain that makes you want to eat, that part of the brain gets affected either by the cancer or the cancer's little chemicals that it produces, or from the chemotherapy. So people don't feel like eating. They look at food and they're like, ugh. The person who could just like eat up a whole plate of spaghetti, they look at spaghetti and they're like, why are you giving me, right? So that is something that we see, and that is what we call as anorexia. The second term that I hear often from patients is called cachexia. Like, yeah, he's getting cachexic, he's losing weight, right? So they're usually right. Cachexia is the outcome when people don't eat. So what we see is anorexia and cachexia together. So if someone loses their 5% of their weight unintentionally, where people are losing more muscle than fat, which is unfortunately what happens. So you lose good weight when you have cancer or getting treatments. So that is what is called as cachexia. It is very common. I mean, in advanced diseases, I mean, the body just does not want to have food, and then as a result starts losing weight. So we see both of them together. So instead of saying this person has anorexia and losing weight, we say, oh yeah, this person has anorexia cachexia syndrome, or anorexia and cachexia together. So it is common not only in just cancer. I mean, we see this in patients, people who smoke a lot of cigarettes and are super thin. So, I mean, you would see them continuously lose weight. That is something that we see in COPD, which is obstructive pulmonary disease. We see them in heart failure. We see them in AIDS. All these diseases, we see people losing weight. But the incidence of this in cancer patients is super high, especially if the disease is getting worse or the cancer is getting worse. We see almost 50% of more than 50% of cancer patients lose weight. So that is important to tackle at that point. Next slide. So what happens when people don't eat and they get anorexia and cachexia? First of all, when people don't eat and they're burning down more muscle than they're putting in, or they're burning down more fat than they're putting in, they're going to eat up their entire body slowly, gradually, and basically that will lead to a very thin and weak person, and that can increase morbidity, and that can increase the risk of mortality. So that is why I push all my patients that if you're continuing to lose weight, we need to get you fed. We need to find ways to get your appetite high. And secondly, the thing that happens is that if someone is very weak, let's say if you go to Dr. Biram or if you go to Dr. Eisner, as Alan said, and you're losing weight, he's going to be like, listen, you're already losing weight. I cannot treat you right now. I'm going to kill you with this treatment. So the idea is that if someone is losing weight, or if they're actively declining and they have anorexia and cachexia, they may not get more further treatment. So that is why it is important to keep eating. They have increased incidence of depression and anxiety. It takes the term hangry to a whole new level. People get angry, they get anxious, they get depressed. So that is why it's so important to make sure that people eat so well. And secondly, I mean, people, when they lose a lot of weight, or if their body loses the proportion that they preferred, I mean, there's a disturbed self-image on top of that. And I can tell you from my own experience, my mother, who passed away last year from cancer, basically what happened is that I used to get in fights with her. Like, you are not eating. Why aren't you eating? I mean, she was a very smart lady, but the idea was that it would just not get inside her head that she had to eat. So this led to a conflict between me and her, knowing what would happen. The point is that all these things, increasing morbidity, mortality, limiting of treatment options, bad self-image, and fights among the patient's caregivers and patients themselves, these become very important issues with advanced cancer. So this is kind of important. So we need to tackle that right away. Next slide, please.
Doc, could you comment on what sort of rate of loss you would define as anorexia cachexia, as opposed to, say, more or less a normal weight loss? And what level of BMI should we get concerned at?
So good question, Mr. Khan. So number one part of your question is, what amount of weight loss would you say would amount to anorexia cachexia, and at what level it would become dangerous? So the answer is, everyone is different. I'll tell you, I'm, let's say, about 170, 180 pounds, right? And someone else is, let's say, 350 pounds. So and a third person who's like 80 pounds. If someone is who's only 80 pounds and continues to lose a pound, pound and a half every month, that is dangerous. But for a person who's 350 pounds, I mean, losing a pound, pound and a half is not as dangerous. So if you were to ask me about the proportion, I would say that if they are, for an average person, if they are losing more than 2 or 3 pounds a month, that is a dangerous scenario. You want their weight to be good. You want that weight to be muscle weight. You don't want that weight to be fluid weight. You don't want that weight to be fat weight. You want that to be muscle weight. So I tell people, not only do I want you to eat, I want you to walk. I want you to run. I want you to lift weights. It's a tough call, but the idea is that I want to make sure that the food that is going in, or the food that they're consuming and trying, is going into the right place in the muscle and not into fat. So that is the first part of the answer, that basically if a person is losing a significant amount, I would say 2 to 3 pounds a month, that is very dangerous. Even 1 to 2 pounds sometimes is very dangerous, because if you multiply that by 12 months, that's 24 to 30 pounds. That's a lot of weight, right? For a person who's, let's say, 150, 160 pounds an average weight, that's a lot of weight to lose. The second part of your question, Mr. Khan, I've forgotten the...
At what BMI level should we start getting concerned?
Good question. I would say we should always target being in a BMI level between 20 and 25. So I'll give you an example of why I don't like to talk about BMI. Let's talk about Mr. Arnold Schwarzenegger from 1983, when he used to be super buff, right? If you look, he was in the world's best shape, muscle, just muscle, not an ounce of fat on him. But guess what? If you do his BMI for the 270 pounds that he was and 6'4" height or 6'3" height that he is, his BMI was 45, right? He was fat for all practical purposes. The problem with BMI is it does not take into account that whether that is good weight or bad weight, right? Someone who is 4 foot 8 inch and has a body weight of 140, I mean, their BMI is not going to be high, but at the same time, they will be considered fat. So what the answer would be is that our goal should be that people should not lose weight. But if we were to define a term, I would say if people's BMIs are going below 22, 21, I start getting very concerned, right? That is the point when they're going from being low normal on the regular BMI to below 20 or 20.99, as I think some people say. At that point, they start hitting that boundary of being underweight. And that becomes dangerous, because when people are losing more muscle than fat, we know that their muscles are taking a bigger brunt than they should be.
All right, thank you.
Thank you. Good question.
Dr. Hamza, I have a question from the chat. I'll read it. Ever since I went through chemo, my taste buds have not been the same. There is a metallic taste that affects my eating. Will this eventually go away?
So this is a wonderful question, and unfortunately, this is a question that affects a lot of our patients. The answer is, in most cases, gradually this goes away. Once you stop the chemotherapy, a certain kind of chemotherapy, these side effects continue to gradually go away. Initially, they go away fast, and in the latter part, they're slower to go away. What I mean to say is that they go down in this pattern of like initially very quick and later very slow. But usually they go away. The second part is that yes, I know it's metallic. I know it tastes icky. I know it tastes bad. And in certain people, what I recommend is that there are a couple of mouthwashes that are available in the market on a Target or a CVS or any place that you go. It's called a Biotine mouthwash. It can take away some of that feeling of ickiness and then that metallic taste from your mouth. And Tracy Meisner, she will talk about certain foods that can help with that as well. So I always tell my patients that there's a good chance that it will get to a point where you will not feel this metallic taste as much. But in most cases, there's a good chance that you will recover completely, almost completely in certain cases. So that's how it works out. Does this answer the question?
Thank you.
I have a question, doctor.
Mm-hmm.
I'm on my third go round of chemotherapy for ovarian cancer stage 3, which was July of 2017. They say now that I am platinum resistant, so I'm on the dioxazine. I can't think of the whole word, along with Avastin, which I know is not as successful with survivors of ovarian cancer. So I have taken some steps of my own, going more toward the paleo diet, cutting back on carbs and sugar. And I mean, I've lost weight, but I am within a good BMI. My biggest issue is constipation. But is that something that you agree with as far as trying on my own along with the medication, whether it works or not, that it would help?
Good question. So Kathy, tell me one more and give me one more answer. And the question is, what do you specifically take in your paleo diet?
What do I do as far as eating? Okay, I stay away from bread, pasta. I do cheat like maybe once a week, but sugar. I mostly like have an egg and a little bit of fruit in the morning and eat more of the vegetables and spaghetti squash instead of pasta. So basically, from what I've read about cancer feeding on sugar, is that a good way to go as far as my mortality? I don't know, but keeping me healthy during this process. Okay, Kathy, first of all, this is a great question, and I'm sure a lot of people have this question and or have gone through similar circumstances. So the answer is, I always recommend a balanced diet. So yes, I mean, there is some data that shows that if you take a lot of sugar, if you drink canned soda every day and all those bad things that all of us do and try because we have such little time and whatnot, and they taste so good, it can increase the incidence of cancer. Now, the answer to the second part is that we have not seen, yes, people who take more sugars and stuff, there's a chance that their tumors, quote unquote, may grow fast, but there's no solid data on it. If you look at real research, there's nothing solid on it or something that has been done in the long term to figure it out. So killing yourself and not having sugar is if it decreases your caloric intake and on top of that you're losing weight, then that becomes counterproductive. So what I tell people is that if you're not doing super unhealthy things and you want to cheat less, I mean, not just even one day a week, if you want to cheat 3 or 4 days a week, it's okay. I like that.
This is the only cheating you're allowed to do. All right. Otherwise,
Well,
Mr. Keeney would not be happy.
Yes, he's sitting next to me listening. And to add to that, when you were talking about fasting, I have been doing the 200 calorie a day before, during, and after my chemotherapy, hopefully putting my body in ketosis, where the chemo is supposedly concentrates more on the bad. And I don't know, I'm trying everything at this point.
Kathy, you're doing a wonderful job. It's not easy to go through this since 2017 like you have. You've been fighting bravely and you've been doing a wonderful job. There's something that you're doing right, okay? So congratulations, you're doing something right. 3 years, 4 years down the line, after stage 3, this is good. Eat what you like, make it balanced. If you want to cheat a little bit here and there, it's okay. All right?
All right.
Good.
Thank you.
Could you,
Anytime.
Doc, I follow a very rigorous ketogenic diet, like less than 20 grams of carbs per day. I believe it's helping me pretty dramatically. But could you just elaborate on why you think a balanced diet might be a better approach, or maybe talk about what evidence you would need to change your mind? Because, I mean, nobody's going to pay for a clinical trial on fasting or ketogenic diets.
No, it's a tough call unless they make a patent on it. So, Mr. Khan, that's a great question, and I'll give you the answer to that. And the reason is that when I see patients, right? I mean, discipline is not one of my best virtues, and I know a lot of patients have this issue. And Kathy said that she cheats, quote unquote. Kathy, that's not cheating. Number one, okay, that's just being human. But I can tell you that a lot of people find it difficult to find that rigorous regimen of keto diet to manage and do for a long-term time. So it all depends on, and if you see these new things, the nooms and all those things that they're coming along, I mean, they work more on your psyche and they make you a stronger person mentally to follow those things. So my answer would be that if you can follow it, yes, that I think there are some studies there's some older data that has shown, actually from 2018, 2019, there's some data that has shown a lot of benefit of it. But at the same time, they didn't put it in all people because it was very difficult for everyone to follow that level of discipline. So Mr. Khan, kudos to you, man. I mean, seriously. Right. I can tell that as I'm driving back from work and I'm hungry, and as much as I don't want to stop over for that McDonald's, sometimes I do because I just gotta eat.
Oh yeah, you're absolutely right, Doc. I miss my McDonald's.
Yeah, I know, man. You're missing big stuff. But at the same time, the point is that
so don't touch it. So
I know, but amazing. I mean, you should be the spokesperson for one of these guys.
I can't do that.
No, but right? Thank you for your point of view. I appreciate your candor.
I do too.
Yeah. All right. So we'll go quickly because we're eating into Tracy's time now. So number one, whenever someone comes to me, I do a little dietary counseling myself, and I say, listen, you got to eat this stuff. You don't eat this stuff. You do this. You don't do this, right? So all these things that Tracy will talk about in far more detail. I talk about feeding tubes, and people say that feeding tubes, sometimes they're helpful and sometimes they're not. So I always say feeding tubes are great when you're using them temporarily. Feeding tubes are not great, and the data is not good if someone has got unfortunately, a terminal cancer. Then you're just putting food in, and that food is going to get in the stomach. The stomach won't be ready for food, and it's going to get thrown up, and it will go into the lungs, and people can choke and aspirate. So permanently, it's not good for certain head and neck cancer patients. We definitely use it, but not for permanent use, especially if the cancer is spreading, because at that time, you're just trying to push food into a stomach that may not be able to accept it and cause more issues. TPN, so that's a tricky subject. TPN is tricky because yes, TPN works really great if someone gets a surgery on the GI tract or someone gets into a car or motor vehicle accident or something. These things are great. You can give some people some of this nutrition and some hydration. But in terminal cancers, when cancers are multiplying like crazy and all the nutrition that is going into the person primarily is being used up by the cancer and its growth, these things can be counterproductive. So for shorter terms, great. For longer terms, permanent use, no. That becomes difficult, and actually that becomes very difficult because the level of testing and the blood tests and investigations that you need, the diagnostics that you need, become overwhelming for a lot of families. Next slide, please. All right, so we already talked about marijuana, right? Marinol. Why do we use it? Cannabinoids. So again, there is a component THC that makes people eat more. CBD not as much, THC more. And THC is relatively more, is a controlled substance. CBD is not. And you can see CBD supplements all over the place. Every mall, every Amazon place that you go to, CBD is all over the place. We use a very small dose of it. We use about 2.5 to 5 milligrams twice a day, and it can sometimes help with the appetite. Now, this is a capsule that is available. It's called Marinol. It's called Dronabinol. So if someone has nausea and low appetite at the same time and other medications have not worked for them, then this is a great medication. I worry about the side effects from it. Some people get high. Some people also are unable to drive and can become a liability for themselves or someone else if they're driving and they're high. So, and if you get pulled over, that's another issue. Now, in addition, in certain people, when you give marijuana supplements, they get very confused. And in older people, we see this very often. Yes, you give them that, but they're out for 3 days, or they're confused, or they're looking at stars in the sky. And these are mostly people who have not used marijuana before, for this data that we have. So if side effects do not preclude it, if insurance does not preclude it, because sometimes it's very hard to get approved by the insurance, it's okay. But to use it as a first-line drug for low appetite, I don't think I'm not ready for it based on the data right now. I'm a very pro-green person, but I really wish marijuana supplements had shown more real evidence on real clinical trials, and unfortunately they've not. On Facebook and Twitter, they do a wonderful job, not in real science, unfortunately. Next slide, please. Another thing that we use is Mertazapine. It's something that helps with depression and low appetite together. Another thing that Mr. Khan actually brought up is that why don't I say that people should only go on certain diets? And the reason is because when you go on a very specific diet, sometimes people can miss certain vitamins, right? So that is another thing that I tell people, do the vitamin supplementation. It's very important. Herbologicals, a lot of Chinese and herbal and Eastern medications like ginseng, ricochinto, and all those things, ricochinto and all those things. Yes, they can sometimes give you a little more boost of energy and you can eat a little bit more, but there's no long-term data on it. So herbologicals, they are not a greatest when it comes to that. Marijuana supplements, medical marijuana, some people have seen to have good effects. Some people, they've just spent $600 on something which did not do much for them. So it's a mixed plate there. Next slide. All right, we're going to talk about poop now in the next 10 minutes or 5 minutes. Listen, when you get pain medications, when you don't eat, when you don't drink, when you don't walk, which are all the things that happen when you have cancer, you get constipated. Add on that, on top of it, a pain medication like oxycodone or morphine or something for pain for your cancer, that makes the constipation even worse. So this is the second thing after pain that I treat, constipation, all the time. Next slide. So before you say that, doc, I'm constipated, so your doctor will always ask a couple of questions. Number one, how frequently are you pooping? And if someone is moving less than 3 bowel movements a week, that is constipation. If someone has difficulty in passing the poop, that is also constipation. If it's hard stool, or if there's less than 3 times a day, that's when you call it constipation. So anytime you go to a doctor, they'll go into specifics of your crap that you don't want them to get the specifics into, but this is how they think about constipation. All right, it's all about this crap. So next slide. So whenever I get a patient with constipation, I usually say that optimize your oral hydration. Make sure that you drink a lot of water. If poop is hard, you got to soften it, right? Drink some water, like Kathy's drinking right now, right? That's great. So that's one. And then walk. I mean, when you walk, your gut walks, right? If you don't walk, your gut is not going to walk. It's going to be sitting there and not do anything and keep that, you know what, inside, right? So the idea is that walking makes the gut go. I always say to people that if you are not going to the bathroom regularly, try to set a time. When you go to the bathroom, don't wait for the poop, but make the poop come at a certain point. Some people do this when they're working. They have this cup of coffee in the morning and they go to the bathroom because it's the set time that they have before work or during work or whenever. The idea is that if you cannot poop, find a time. Don't let that stuff sit inside you. The longer it stays inside, the harder it's going to become and the harder it's going to be to come out. All right. So make sure you poop regularly. For that, regularly means some people go every other day. Some people go twice a day. Some people go every day. Try to find out what that routine is and stick to that. All right. Next slide. Constipation, I always tell people there's a mush and push logic to it. In order for the poop to come out, first you got to make it a mush. And then the colon's got to give it a push. Mush and push. The idea is that if you're constipated, you have to take a medicine that makes it a mush. Miralax, Docusate, Colace, they're all mush medications, right? Senna, Lactulose, these are push medications. So whenever you get Senna and you don't get Colace, whenever you get Colace and not get the push that comes from Senna, you're just making a flood in there, and that flood ain't going to come out till you give it a push, right? You need both of them together. And this becomes all the more important when you are taking pain meds. Jackie asked a question down below. Castor oil okay? Jackie, castor oil is okay. I grew up in a third world country. Castor oil is all we had. But what happens after castor oil? You make sure that the cleaning ladies come in and clean up the house afterwards, all right? That stuff is potent. But if you take it, more power to you. But yes, castor oil works. Castor oil really works. Patrick asked down below, pushing makes my bladder bleed. So yes, that can be a problem in certain people. So if you take a certain medication that makes your bladder go into a spasm and bleed out, you have to be really careful. Then you can only take the mush, the Miralax, and try to get out the poop by going on a scheduled time and taking some more fiber and stuff, and that can help as well. All right, next slide. First line drug whenever someone comes to me is prune juice. Easiest thing, something that your mother gave you when you were a kid and you didn't poop for 2 days, works really well. Simple, easy to get. Tastes okay. I'm not a big prune juice fan, but yeah, sure, right? The second thing is the push, right? Senocot, Senna, you can use that. Third thing is the mush. I usually use number 2 and number 3 together, the Colace and Miralax, and number 2 or 3 and 4 together, Miralax together. Let's say if someone has liver disease, chronic liver disease, and they're constipated, or they've used the mush and push logic and it has not worked. Then I move to a medication called Lactulose. It's something that is not available over the counter. Your doctor can give you a prescription for it. And it makes you poop. It does make you go, all right? And if that doesn't work, then we go to Ms. Cruz's recommendation of going to castor oil. I've never used it on any of my patients over the last 10 years, but just because my mother gave it to me once and it just was really potent. So that's why. I don't want to give you my examples. Let's say it's day 4, nothing has worked. Poop has not been able to come out. In that case, what I do is that I give people suppositories and enemas. Unfortunately, this is a terrible thing to do because first of all, there's a bleeding risk to it. I mean, and it's uncomfortable, right? So what I do is that I usually try to avoid that. And if you do a good mush and push logic and good lactulose, you won't need to do suppositories and enemas. I always tell, if you're going to a day 4, day 5, and you're going to a suppository and enema, either your doctor sucks or you've not followed what your doctor says. So there are only 2 reasons to it. And I can tell you that my patients usually do not need, if I really scare them out of poop, so they usually don't need to go to that stage of horrific enema pushing and suppository pushing. Next slide.
Do you want to address the chat question?
Let's do that. I got a couple of them. I can answer some of them. All right, so let's go up. Okay. Castor oil, okay. Yeah, sure. I have issues grasping, Jessica wrote that. I have issues grasping my bowel schedule and frequent small hard stools. I've had a colonectomy, so I have probably half my large bowel. Any suggestions on how to get a routine? I take Colace 2 times a day and Fibercon pills twice a day. So Jessica, that's a very good question. Unfortunately, when you have colon cancer or something similar, when you get your colon taken out, the body goes into this phase where people either get diarrhea or they get constipation or they get diarrhea and constipation together, which is a very weird concept, but it does happen where people go a couple of times a day and it's small little poops. So usually what I say is that on the days when you are becoming more hard, your stool is becoming hard, go for the softener. On the days when you feel that you're more loose and you're going more frequently, add the fiber. it has to be a balance. Unfortunately, that has to be changed every day. Just because the colon has been changed, the body does not do that function, and we have to do that from our side. It becomes difficult. So I understand where you're coming from on this, but it's a difficult issue, and there's no rhyme or reason. There'll be days when you'll be extremely constipated, and there'll be days when you'll pass little stool, which is very hard, and there'll be days when you'll be completely loose, and that sucks sometimes. So Patrick asked this question, which is, do you recommend Metamucil and Psyllium husk powder? The answer is yes. The question is when this is yes. Now, the reason why I use Psyllium husk is sometimes when people have very watery stools and they are not on pain medication. If someone is on a pain medication where the gut is already slowed down and you put them on Psyllium husk or Metamucil or one of these products, you're just adding cement to bricks. And that thing is very hard to pass. That is, if you're on pain medications and you're taking Psyllium, it is the biggest disservice you can do yourself. And you're going to pay through your butt, literally. So the point that I'm making is that Psyllium is good for almost all kinds of constipation and some diarrhea, except for when you're on pain medication or your colon is slowed down. And some of it also goes to Jessica's question that on days when her colon is putting small stool and hard stool, that those days, if she takes that day, those days will be tougher. All right, next slide. All right, so this is a typical schedule. You guys don't have to worry about this. This is for patients who take pain medications. And I don't want you to go into too much of this, but the idea is that if someone is getting constipated, I usually print this out and give it to my patients, especially when they're on pain medication. When I tell them take sen and colace together twice a day. On day 2, if you don't poop, you make it 2 tablets twice a day. On day 3, if you still don't poop, make it 3 tablets twice a day. Add some Miralax to it as well. Add some Lactulose at that point. Day 4, if you still don't go, add Lactulose twice daily. Lactulose every 30 ml, 30 grams every 12 hours. Even if that doesn't work, then on day 5, you do all that and do a suppository followed by an enema. I can tell you that on day 3, everyone is almost going at that point. But the idea is that you shouldn't have to go to day 3. You need to have a time when you go to poop, and you should follow that schedule. That should not get messed up. Next slide. Question. Good. So we talked about all sorts of crap, all sorts of barf, all sorts of picky eating. That's pretty cool. That's good. All right. Listen, Tracy, you're up. I'm so sorry I ate into 20 of your minutes. 26 of your minutes. I'm a terrible human being. I am so sorry.
You're putting me out of business. You were fantastic.
Well, listen, you're going to do awesome. So let's do this. You start. Okay, I'm here.
Okay. What a tough act he is to follow. He totally put me out of business. And I have to say, you all ask outstanding questions, both from a medical and nutrition standpoint. And in terms of the more diet-specific questions, I could not agree with Dr. Habib's answer more. So again, putting me out of business. All right, Alicia. So we can move on to the next slide. So as Dr. Habib very eloquently said, you know, unfortunately, a lot of side effects can occur during cancer treatment, whether it's chemo, radiation, or a combination of both. Symptoms associated with cancer treatment can definitely negatively impact your quality of life and can result in a decline in nutritional status, potentially leading to malnutrition. Some of the most common symptoms include dry mouth, nausea, and constipation, none of which are pleasant. The most distressing symptoms really tend to be dry mouth, diarrhea, and stomach pain. And effective symptom management can definitely positively affect comfort, keeping your weight stable, and tolerance of treatment, which really is the crux of the matter, right? You have to be on treatment. We want it to work. Next slide, please. So from a nutrition standpoint, which symptoms or side effects can really impact your nutritional status the most? Unfortunately, there are many, and I will do my best to try and get to as many of these as possible. They include, but are not limited to, unfortunately, anorexia, poor appetite, early satiety, or an early sense of fullness soon after eating and drinking, taste and smell changes, constipation, diarrhea, nausea and vomiting, dysphagia or difficulty swallowing, mucositis, esophagitis, xerostomia or dry mouth, and fatigue. Next slide. So anorexia and poor appetite. I know Dr. Habib already gave us a lot of great information about this, so I'm going to try and get through some of these slides quickly so that I can get to tips for that from a nutrition standpoint. So as he mentioned, anorexia is the loss of appetite or the loss of desire to eat. Loss of appetite is one of the most common problems that occurs with cancer and treatment. And poor appetite or loss of interest in food can be related to so many different factors, including nausea, vomiting, constipation, different medications that you might be taking, depression, pain, and loss of or changes in taste. Next slide. So what are things you can do from a nutrition standpoint to really offset these horrible side effects? So this first one, view eating as part of your treatment. Food is medicine and you can't miss a dose. But let me tell you, both professionally and personally, I realize that in many instances, this is much easier said than done. Believe me, I understand that when you're experiencing a variety of these side effects, especially when they're in rather unfortunate combinations with each other, eating is much harder to do. And as Dr. Habib mentioned, you know, he unfortunately witnessed his mom going through cancer and treatment, and he knew that she needed to eat and she knew she needed to eat, but she couldn't just physically do it. And sometimes that's just the unfortunate reality. Sometimes you just physically cannot. And when that's the case, my best advice to you is to really try and eat those small, frequent meals. Oftentimes when it's physically difficult to eat or when you just have no interest or desire to, seeing a full plate of food placed in front of you can feel like being told to go out and climb a mountain. Okay, just the sight of that full plate can be really upsetting and off-putting. But by having smaller portions of foods, not only visually can that be helpful, but from a digestive standpoint, it's a lot less food for your body to have to process at a time, which can really help you feel better and make eating more manageable. Okay, you might unfortunately have to eat based on the clock and not your own internal hunger cues, which might be altered or not present right now. Okay, so instead of waiting for your body to tell you when it's time to eat, you might be waiting for your watch to tell you, okay, it's been about 2 hours, I need to try and eat something. It can also be helpful, depending on your circumstances, to really try and choose high calorie, high protein foods like eggs, lunch meats, cheese, yogurt, nut butters, dried fruits, granolas, protein bars, and avocados as tolerated, because those are foods where even if you're only able to eat them in small portions, they're packing a pretty big calorie and or protein punch at that point. So a little goes a long way. It can definitely also be helpful to drink non-carbonated liquids in between your meals to prevent that early sense of fullness at meals. Sometimes when you're drinking fluids, especially large volumes at the same time as your meal, your stomach can fill up on fluid, making it that much more challenging to get some of those foods in, okay? And also realistically, you may be experiencing times when your appetite really changes like the tide, where maybe first thing in the morning, eating is the last thing that you're able to do, but by late afternoon or early evening, it's a little bit easier to get those foods in. So if you have certain times of day where your appetite is a little bit better or eating is easier both physically and mentally, definitely try and take advantage of those times and eat a little bit more when you're feeling well. Next slide, please. Other tips. So again, eating when your appetite is at its peak and eating a little bit more when you're physically and mentally up for it. Really try and choose foods that are easy to prepare and serve, especially if fatigue is present and a barrier. When you're exhausted, and have very little interest in food, the idea of cooking a 3, 4, 5-course meal, not really high on the agenda. So trying to go with foods that are easy to prepare, like sandwiches or salads or yogurt parfaits, things like that can be much easier to manage. It can also be very helpful to really try and serve foods so that they're visually pleasing to you and eating in a soothing, calming environment. So trying to eat when you have some downtime, you can relax, even put soothing music or look out a window while you're eating. So there's a pleasant background, not when there's a lot of things going on or when your schedule is a little chaotic. Involving yourself in normal activity and staying active throughout the day can also help to increase your appetite. Not saying that you have to go out there and train for a marathon or do any kind of strenuous exercise, but any kind of light exercise or even your daily living activities that you can do on a regular basis can definitely help to stimulate your appetite and help those hunger feelings from getting there. So the next one, drinking nutritional supplements like Ensure, Boost, Premier Shakes, as needed, those kind of products can definitely help boost your calorie and protein intakes, but please note, you don't have to drink those. I can't tell you how many times I've had patients, particularly patients of mine that have been hospitalized for long periods of time, who have told me, Tracy, I had a bottle of Ensure show up on my tray 3 times a day for a month straight. I can't stand the sight of Ensure. If that's the case, I completely understand that. And if you can't drink those drinks, or you don't want to, or you don't like the taste of them, that's okay. But if there's something that you haven't tried, it might be of benefit to you to try those high calorie, high protein drinks, especially on days when it's easier for you physically to drink than it is to eat. Next slide. Okay, so moving on to early satiety, or that early sense of fullness, okay? Early satiety is that feeling of being full soon after eating or drinking a small amount. So it could be that you sat down and you took a few bites or a few sips of something and you already feel like you ate a whole meal. That's early satiety or early fullness. It can occur, again, for a variety of different reasons, including cancer treatment, or other gastrointestinal issues like gastroparesis or decreased GI motility. Patients who experience early satiety tend to eat fewer calories, protein, vitamins and minerals, and may lose weight unintentionally. Next slide. So what can you do if you're having this persistent early sense of fullness? There are a lot of things that you can do to try and counteract that early sense of fullness, including, again, this is going to be kind of a common theme with a lot of these side effects, eating those small, frequent meals, where again, you're eating those small portions of food, but you're eating much more frequently, about every 2 hours or so, sometimes even more frequently than that if you can only take bites or sips at a time. Again, drinking liquids in between or after your meals so that you're not filling up on liquids in place of foods can be a very helpful strategy for many patients, as well as avoiding foods that tend to be gas causing or gas producing, like Brussels sprouts, cabbage, broccoli, cauliflower, onion, the skins on fruits and vegetables, as well as carbonated beverages like sodas and seltzers. If you find that drinking ginger ale is something that's soothing for you, especially if you find it to be helpful with nausea or other GI issues, my tip for that is to let it go flat first so that the carbonation isn't causing gas and making that early sense of fullness worse. Then there's fiber. Limiting high fiber foods like bran products, whole wheat breads and pastas, oats and prunes can also be helpful. And the reason for that is fiber isn't something that your body can digest. So foods that are high in fiber take your body longer to process. So if you're eating large amounts of fiber at your meals, chances are those foods are going to sit in your stomach and your intestines a little longer than you'd like. And that can also make that early sense of fullness worse. So finding a balance with fiber and staying away from those super high fiber foods can be helpful at times. Again, participating in light physical activity throughout the day to help foods move through the GI tract can certainly be helpful as well. And again, if you're only able to eat small portions of food at a time, we really want to make every bite that you can get in count. So we want to try and go for those high calorie, high protein foods so that those small portions are going a long way. Next slide, please. Okay, so taste and smell changes is a big topic. I get asked questions about this all of the time, and understandably so. Even if you're hungry and you have the desire to eat, if foods aren't tasting or smelling like they should, it can definitely be a barrier to meeting your calorie, protein, vitamin, mineral, and fluid needs. Okay, so common causes. Common causes can include certain kinds of tumors like head and neck tumors. If you've had any radiation to the head or neck area, certain types of chemotherapy and other targeted therapies can alter your taste buds. Mouth soreness or dryness can definitely impact taste, as well as other medications used to treat other side effects or other non-cancer related issues. Next slide, please. So what can you do if everything you're eating and drinking isn't tasting like it should be? Well, a lot of that depends on what exactly the issue is in regards to smell and taste. So I know we had received a question a little while ago when Dr. Habib was presenting about that metallic taste, which I completely sympathize with. If foods are tasting metallic, as simple as this might sound, believe it or not, even switching from silverware to plastic utensils and plastic or glass cups and plates whenever possible can really make a difference. Just the simple act of not having the utensils you're using be metallic can really help quite a bit. If you notice that things are tasting really salty or bitter, that can be counteracted with a sweet taste by using things like honey, agave, fruits, or even fruit-flavored vinegars, marinades, or dressings. If things are tasting super sweet, you can counteract that with something a little more tart, like lemon juice, citrus, or salty taste by adding salt to foods. Another thing, if things are tasting really bland or like nothing at all, you can play around with different seasonings. You can add tart flavors, again, those citrus flavors like lemons, oranges, limes, or vinegars to foods to try and give it a little bit more flavor. You could also add different herbs and spices and seasoning combinations to add flavor to your foods, like basil, thyme, oregano, parsley, mint, lemon balm, cinnamon, cumin, chili powder. All of those different flavors can really add some flavor to foods. You might not be able to taste all of those ingredients, but you might be able to taste 1, 2, or 3 of them enough to where the food is palatable enough for you for it to be easier to eat. Next slide. So what else can you do? So a lot of the times, foods that become the most difficult to eat for many patients are some of those protein foods like meat, poultry, or fish. And if that's the case, marinating those foods, especially meat, in different marinades or dressings for a few hours in the refrigerator can really make them not only more flavorful, but more tender as well. If red meats are tasting poorly, it might be a good idea to try other protein sources that have a little bit more mild of a flavor to them, like chicken, turkey, fish, beans and lentils, tofu, cheese, eggs, nuts, seeds, or nut butters. You could also try fresh fruits and vegetables if you notice that the canned or frozen vegetables you use don't seem to be as flavorful and are harder to eat because of that. Adding bacon, ham, onion, or garlic to foods can also enhance their flavors, especially for vegetables. Despite my profession, even I will admit, bacon makes just about everything taste a little bit better, right? Other things you can do is to try sugar-free lemon drops, gum, or mints. This can be particularly helpful if eating is a challenge because of a bad taste that seems to be lingering in your mouth or on the tongue. Using those sugar-free lemon drops gum or mints can really be helpful with taking away poor taste. Next slide, please. So speaking of that bad taste, what to do if you have that persistent taste where no matter what you eat or drink, there's just a bad taste in your mouth. I know Dr. Habib had mentioned rinsing your mouth with a biotin rinse, which is certainly a great option. If for any reason that's unavailable to you or you're looking for a different option, a simple solution of water, baking soda, and salt can also be very helpful. And you can rinse with that before and after eating as needed to eliminate a poor taste in your mouth. The recipe for making a small amount of rinse would be to add 1/4 teaspoon of baking soda and 1/8 of a teaspoon of salt in 1 cup of water to swish and spit as needed. It's also very important to keep your mouth clean and to brush your teeth frequently throughout the day to help eliminate any bad tastes as well. Other things you can do, and I find this to be particularly helpful when smells are a challenge. Sometimes you might find yourself, particularly if nausea is also a problem, where you're very sensitive to smells, and even just being near foods is off-putting because of their odors. Serving foods cold or at room temperature can decrease foods' smells and tastes. So that can be a helpful strategy, particularly when both taste and smell are presenting a problem. You can also try covering beverages and drinking through a straw to reduce any smells of liquids that you're drinking. Next slide. Okay, so we've gone through about 3 of the topics so far. So I just wanted to take a quick break and see if anybody has any questions. Alicia, any questions showing up?
No, I don't see anything in the chat.
Okay. I'm going to try and keep going through these slides so we cover as many topics as possible. But again, if anyone has any questions at any time, please don't hesitate to ask, okay?
Great.
So, thank you, Jackie. So is tofu good for you? So my answer is yes. Tofu is a great plant-based protein. It's also a great source of calcium and some other vitamins and minerals as well. From a taste and smell perspective, I find tofu to be particularly helpful because it doesn't have much of an odor. And from a taste perspective, tofu by itself is completely tasteless. It takes on the flavors of what it's cooked in. So you really have full potential to flavor it to your own needs and likings by adding different seasonings, herbs, sauces to really get it to taste to where you need it to be to make it palatable. So not only is it healthy from a nutrition perspective, it can really be a great source of protein when you're experiencing those taste and smell changes. And it usually is also very easy to digest when other digestive issues are making some of those other protein sources like beef or pork difficult to digest. Does that answer your question? I hope so. Any other questions? Okay, I'm not seeing any pop in the chat right now.
I have a question.
Oh, sure, please.
Yes, so I get asked by a lot of patients about tofu, and they ask like what kind of protein does it have and how much protein does a gram have and how much, I mean, does it equalize in the amount of meat as far as protein is concerned for caloric needs?
So those are excellent questions, Dr. Habib. And in terms of the type of protein it is a soy protein. And in terms of its protein content per serving, generally speaking, it may vary a little bit from brand to brand, but generally speaking, 1 cup of cooked tofu gives you about 20 grams of protein on average. So it really is an excellent protein source. I know for me, being that I counsel many breast cancer patients, I get a lot of questions about whether or not it's safe for hormone receptor positive cancer patients to eat tofu and other soy-based foods. And the answer to that is yes. Particularly with breast cancer, the research for the better part of the last 15 to 20 years has been showing more and more that not only are those soy foods like tofu and edamame, soy milks and soy yogurt, safe for you to eat, but they may actually have some preventative properties to them. So they absolutely are a safe protein source for you. Does that answer your question?
It does. Thank you so much. No, definitely. I get a lot of questions about this, and I'm a big fan of tofu myself, right? So this is awesome. This is an amazing source of protein. That's great.
It absolutely is. And thank you for your question. Any other questions, or are we okay to move on, Alicia?
We're good to move on.
Okay.
I don't see any more. Yep.
Okay, sorry, I changed my screen, so I'm not able to see everyone's face, because not that I don't like looking at all of your lovely faces, I don't particularly like looking at mine. So forgive me for asking. I just want to make sure that I'm answering everyone's questions accordingly. Okay, so our next side effect to review, which we've already spoken about in great detail, is constipation. And as Dr. Habib mentioned, constipation is a decrease in frequency of bowel movements and or hard to pass stools that can be due to dehydration, medications, or mechanical changes within your GI tract from cancer treatment or other medical issues. Potential outcomes from constipation can include, again, those infrequent or really hard to pass stools, pain, early satiety or that early sense of fullness, nausea, and vomiting. So again, definitely not a pleasant side effect to experience. Next slide. So what can you do from a nutrition standpoint now that we've got all of that great medical information from Dr. Habib? What can we do from a nutrition standpoint to really help keep things moving, so to speak? And really, when it comes to nutrition interventions, fluid and fiber go hand in hand, okay? You can be eating all of those great high fiber foods, like a variety of different fruits, vegetables, beans and lentils, nuts and seeds, whole grains like oatmeal, barley, buckwheat, oatmeal. But if you're not getting enough fluid to stay hydrated and help flush everything through, you can still end up constipated as well as gaseous and bloated, okay? So both of those things really need to pair up together to be effective nutrition management for constipation. And in terms of how much fiber to shoot for, well, that depends on a couple of factors. Generally speaking, you want to gradually increase the fiber in your diet. If you go from a low fiber diet to a super high fiber diet overnight, chances are it's not going to go over well. You can end up really gaseous and bloating. So you want to gradually increase your fiber intake by about 5 grams a day every few days until you reach your goal. Men should aim to consume somewhere between about 30 and 38 grams of fiber daily, and women should aim to consume somewhere between 20 to 25 grams of fiber daily to really meet their needs, or about 14 grams for every 1,000 calories consumed. Next slide. So what are high fiber foods? So high fiber foods include things like fruits, vegetables, particularly those that still have the skins on them, whole grain breads and cereals, popcorn. Yes, I said popcorn. It is a whole grain. Fruit juices like prune and pear juices, dried fruits like dried prunes, dates, apricots, figs, beans, nuts and seeds, as well as lentils. So how much fluid should you really be drinking in a day to stay hydrated and to help prevent and alleviate constipation? The general recommendation is to aim for about 64 ounces or 8 8-ounce cups of fluid daily, but please keep in mind, fluid needs vary greatly from person to person based on weight, labs, and other dietary restrictions. To put it to you this way, for me, I'm 5'2". My husband is a foot taller than me and outweighs me by about 100 pounds. It wouldn't really make sense to tell me and him to drink the same amount of fluid, okay? So just keep in mind that 64 ounces is a general recommendation, and that the recommendation you get from your physician, your dietitian, or other members of your healthcare team may vary accordingly. Other things that can help for constipation include eating probiotic containing foods like yogurt, kefir, and miso. It can also be helpful, as Dr. Habib mentioned, to try drinking somewhere between 4 to 8 ounces of prune juice once or twice daily. I have had patients also have some success with drinking pear juice. So if the idea of drinking prune juice is really not going over well, I know for me, from personal experience of having been given that as a child, I can't stand to look at prune juice. Pear juice can be a helpful alternative if that's easier for you to tolerate. And again, if you're constipated, you definitely want to avoid gas-producing foods and drinks such as broccoli, cabbage, Brussels sprouts, cauliflower, even onions, and carbonated beverages, because that can definitely make discomfort associated with constipation worse. Next slide. Okay. Other things that can be helpful to keep things moving, so to speak. Drinking hot liquids like coffee or tea can help promote the sensation to have a bowel movement. Incorporating an exercise routine to stimulate your GI tract to push everything through can also promote bowel regularity. As Dr. Habib mentioned, scheduling adequate bathroom time can also really be helpful to facilitate having regular bowel movements. So scheduling times of your day that you dedicate to your bathroom time can definitely be helpful. Now, keep in mind, fluid and fiber can be really helpful strategies for managing constipation, but there can be many different scenarios, including when you're taking pain medications, like Dr. Habib mentioned, where fluid and fiber alone might not be enough. And if that's the case, if you feel that you've really done everything within your power to stay well hydrated and eat an adequate amount of fiber in your diet, at that point, it might be time to speak with your doctor about whether or not certain medications or a bulking agent like the psyllium fiber may or may not be helpful at that point. It could be that certain medications and cancer treatments are affecting how your bowels are functioning, and that a bowel regimen might need to be prescribed for you. Next slide, please. Okay, so on the opposite end of the spectrum is diarrhea. So again, diarrhea is an increase of 3 or more stools per day as compared to the usual, or an increase in the liquidity of bowel movements, possibly caused by diet, inflammation, or any irritation of the mucosa of the intestines, certain medications, stress, lactose intolerance, either prior history or new onset, infections, malabsorption syndrome from disease or cancer treatment, antibiotics, and chemotherapy or radiation, particularly to the abdomen and pelvis. Potential outcomes include frequent stools, dehydration, electrolyte imbalances, weight loss, fatigue, nutrient insufficiencies, and or deficiencies. Next slide. So what can you do if diarrhea is happening? And the picture that I included, I put there for a reason, which I'll get to in a minute. Some of the first things that I recommend would be, at that point, you really want to do your best to avoid greasy, fatty, and fried foods. Those foods are difficult to digest to begin with, and they definitely can make diarrhea worse. You also want to try and avoid high fiber foods, such as raw fruits and vegetables, whole grain breads, and whole grain cereals. When it comes to avoiding dairy is typically the most helpful if lactose intolerance is the cause of diarrhea. So if you already have difficulty digesting dairy products, particularly milk and yogurt, it can definitely be helpful to avoid them or to go to a lactose-free version of either or both of those foods if they're the cause of diarrhea. If they're not, avoiding those foods may or may not be helpful. Okay, sometimes dairy can make diarrhea worse if it's already severe. The picture that I included is a picture of foods that are typically referred to as a Brat diet, with Brat standing for banana, rice, applesauce, and toast. Oftentimes, this diet is recommended when you're having diarrhea because these foods can add some bulk to your stool. But I want you to keep in mind, most of us can't really subsist off of only those 4 foods for long periods of time. That Brat diet is typically intended to be used for a very short period of time, typically no more than 24 to a maximum of about 48 hours. Next slide, please. So what can you eat if diarrhea is the issue? Really, the foods you want to gravitate towards are those soft, easy to digest foods like canned fruits, applesauce, bananas, mashed potatoes, broth-based soups like a chicken noodle soup, broiled or baked meat, poultry and fish, eggs, noodles, rice, and oatmeal. When it comes to vegetables, you don't have to stop eating vegetables. Mashed potatoes are not the only vegetables that you can eat, but I do suggest that you remove the seeds and skins and that vegetables be cooked. They're going to be easier for your body to digest at that point. And again, one of my favorite recommendations, eating small, frequent meals where you're aiming to eat about 5 or 6 small meals throughout the day instead of 2 to 3 large meals can be helpful for, again, the same reason of it's less food for your body to have to process at a time. Under certain circumstances, you can also try adding sources of soluble fiber, such as applesauce, bananas, oatmeal, potatoes and sweet potatoes without the skins, to add some bulk to your stool. Fiber supplements like pectin or psyllium fiber, as Dr. Habib had mentioned earlier, can also have the same effect and can be very helpful to adding some bulk to your stools so that they're not so loose. Next slide. It's also important, again, to avoid gas-causing foods, particularly those that contain sugar alcohols like sorbitol, xylitol, and mannitol. And foods that typically contain some of those sugar alcohols include sugar-free drinks, candies, cookies, and gum. It's also very important to make sure that you're staying well hydrated. You can end up losing a lot of fluid and electrolytes like sodium, potassium, and chloride in your stools when you're having diarrhea. So it's very important to sip on clear liquids throughout the day. So what are clear liquids? Examples of clear liquids would be things like water, clear juices like apple or cranberry juice, broth, Jello, electrolyte solutions like Pedialyte, and decaf or herbal teas. You can also, it's also important to increase the amount of fluid you're drinking to replace lost fluid. So if you're having multiple loose bowel movements in a day, you're really going to want to make sure that you're drinking more than you normally do to replace that fluid loss. And at that point, it can be really helpful to consider drinking an electrolyte solution like Pedialyte or fruit juices and broth to help replace, again, those lost electrolytes like sodium and potassium. Next slide. Dr. Habib and I both have talked a lot about poop and what to do about it. So I just want to see if anyone has any additional questions about either constipation or diarrhea at this time. Okay.
I don't see any on the chat. Does anybody have any questions? You can unmute yourself or chat.
Okay.
Nope.
So I'm gonna move on to interventions for nausea and vomiting. So again, both can be caused by chemotherapy, radiation, immunotherapy, pain, taste changes, fatigue, constipation, certain medications, psychological factors, and many other causes. And it can certainly lead to dehydration, electrolyte imbalances, weight loss, nutrient deficiencies, and/or deficiencies. Next slide. So some interventions for nausea and vomiting. You definitely want to make sure that you're taking nausea medications as directed and time meals when those nausea medications are working at their best. Being proactive and staying ahead of your nausea can really make eating a lot easier when you're feeling that way. By getting the nausea under better control before you start eating, makes eating that much easier. Again, doing those small frequent meals where you're eating smaller portions about every 2 hours or so can also make eating a lot more manageable physically and mentally when nausea and vomiting are a challenge. If smells are making nausea worse, really do your best to avoid food preparation areas to limit your exposure to those bothersome smells. And even avoiding foods and fluids with strong odors. If something that you're drinking, whether it be just something you're drinking to stay hydrated, or if you're taking a liquid medication, placing straws with strong, using straws to drink those liquids in a cup with a lid can really be quite helpful. Try eating cool, light foods that have very little odor to them, like fruits, yogurts, puddings, cold sandwiches, cheese and crackers, and smooth nut butters can also be a helpful strategy, as well as avoiding really greasy, fried, high-fat foods that are difficult for you to digest. When you're nauseous, the last thing you want to do is have a high-fat or high-fiber meal that's just sitting there waiting to be digested. It can also be very helpful to try eating bland foods like rice, noodles, toast, crackers, pretzels, ice pops, oatmeal, and broth. Next slide, please. When you're nauseous, it can also be very helpful to keep your head elevated for a good 30 minutes after eating. Lying down immediately after eating can really throw a wrench into things and can make nausea worse. So definitely try and stay upright for at least a half hour after you finish your meal. Try not to, if you're, like Dr. Habib had mentioned, if you're having profuse vomiting where it's very challenging to even keep fluids down, try not to drink anything until you have the vomiting under better control. And really at that point, it really is best to reach out to a member of your healthcare team, whether it be your physician, your nurse practitioner, to get further guidance to prevent dehydration. In those instances, really try and drink small amounts of clear liquids, like electrolyte drinks like Pedialyte, apple and cranberry juice, flat ginger ale, water, or broth, so that you're not only getting fluid, you're also getting some electrolytes back in you to replace what's been lost from vomiting. Once you are able to keep down clear liquids consistency, try a full liquid or a soft diet. So what do I mean by full liquids? Full liquids include things like cream of wheat, pudding, ice cream, and milk, in addition to those other clear liquids. Soft foods include things like noodles, eggs, rice, and mashed potatoes. Next slide. Dysphagia. So dysphagia is difficulty swallowing, and for all of the obvious reasons can really make eating and drinking very challenging. Dysphagia can lead to coughing, choking, the feeling of food getting stuck, weight loss, dehydration, malnutrition, and again, those nutrient insufficiencies and deficiencies. It can be due to a variety of different reasons, including some type of mechanical obstruction in your esophagus, compression of the esophagus, some type of neurological dysfunction, oral or esophageal thrush, or severe mucositis or esophagitis, or sores in the mouth or esophagus due to chemo or radiation. Next slide. Okay, so again, here's a picture just reiterating some of those symptoms of dysphagia. You might notice choking when you're eating or drinking, coughing during or after swallowing, coughing up or even vomiting foods during and after eating, having a weak, softer voice than normal, aspirating your food, which happens when your food or when foods or liquids go into your lungs instead of your stomach. You may notice excessive saliva or drooling. You might have difficulty chewing or trouble moving food to the back of your mouth, and also having food sticking in your throat and not going all the way down as you're trying to swallow. Next slide. So what to do for difficulty swallowing? It's very, very important to use good posture when eating to prevent aspiration or to prevent foods and fluids from going into your lungs instead of your stomach. So you definitely want to make sure that you're seating upright and that you're not lying down or slouching significantly when you're eating. It's also very helpful to avoid distractions and limit talking while eating so that you're really focusing on chewing your foods properly and really to the point where it's liquefied before you swallow. It can also be helpful at times to take double swallows just to make sure that those foods have cleared before you go on to start taking other bites. Choosing moist foods of similar textures to form a cohesive bolus in your mouth can also make foods easier to chew and swallow. And it can also really be helpful to chop, shred, dice, or even puree or blenderize foods as needed to make them easier for you to swallow and manage in your mouth. If you notice that you're coughing a lot or having difficulty or pain with swallowing liquids, I would recommend considering using a thickener to add to liquids to make them a little bit thicker to allow for a safer swallow. I would also recommend avoid using straws that place foods in the back of your mouth. And at that point, you might want to talk to your doctor or other members of your healthcare team about getting a referral for a speech language pathologist. A speech language pathologist is really an expert who has the skills to manage your swallow function to determine what could be causing the problem and to give you more effective medical strategies on what's safe for you to try and swallow by mouth at this time. Next slide. Okay, so moving on to mucositis or esophagitis. I apologize for the graphic picture. My 10-year-old daughter yelled at me so much about this picture saying that it was graphic, but I wanted you to be able to see it so that you know what it looks like and you know what to look for when you're experiencing pain in your mouth. Mucositis and esophagitis is inflammation of the mouth or esophagus, which is usually described as painful, irritated throat or the feeling of a lump in the throat. Accompanying symptoms can include that feeling of indigestion, esophageal reflux, belching or excessive burping, that feeling of fullness or early satiety. And it can definitely lead to weight loss, nutrient deficiencies, and malnutrition because at that point, eating is painful and very challenging. Next slide. So when this soreness is present, you definitely want to choose foods and fluids that are lower in acidity and avoid things like alcohol, caffeine, tomato products like tomatoes, and ketchup, and tomato sauces, vinegar, citrus juices, hot peppers, and pickled foods. You want to try and choose foods that are less spicy and avoid chili powder, curry, cloves, red and black pepper, and hot sauces as well. So what can you eat at that point? It can be really helpful to try and choose foods that are softer in texture and easier to manipulate in your mouth and swallow, and things with added moistness, sauces, or gravies to them. Things like cream soups, mashed potatoes, eggs, yogurt, tofu, and puddings can be much easier to manage in your mouth and to swallow when this occurs as well. It might be helpful to prepare smoothies and shakes with low acid fruits like melons, bananas, or peaches, and add things like yogurt, milk, and/or silken tofu so that you can make high calorie, high protein drinks for when drinking is easier to do than eat. And it also helps to serve foods that are cold or at room temperature. Extreme temperatures can really be quite painful in the mouth and throat when esophagitis or mucositis is present. So serving those cold foods can really be quite soothing. Next slide. It's also, again, important to practice good oral hygiene, and it can really be quite helpful to rinse your mouth frequently, again, with that simple solution made with water, salt, and baking soda. This mix can be also used for gargling if the pain is more so in your throat and not just your mouth. So you can also gargle with a solution like that as well. If you have dentures, it's very important to keep dentures clean and limit their use if they're causing irritation during meal times. You can also try sipping 1 tablespoon of honey dissolved in 1 cup of water to have a soothing effect on the mouth and throat as well. I would also recommend avoiding carbonated beverages and avoiding smoking, chewing tobacco, and alcohol, all of which can be significant irritants to the mouth and throat. That other bullet point, depending on the type of chemotherapy drugs or treatment drugs you're receiving, if you're receiving certain types of chemo, like 5-FU or adriamycin, it may be helpful to consume ice chips or an ice pop during the administration of those drugs. But again, that's something that you can talk to your doctor or other members of your healthcare team on, so that it's really tailored more towards the specific regimen that you're on. Next slide. So xerostomia, or dry mouth. I know all these fancy words for these horrible side effects. So what to do with dry mouth is the biggest issue. Really try and sip liquids throughout the day so that you're keeping your mouth moist throughout the day. Trying to eat foods or drinking things that are tart can stimulate saliva production. This can be very helpful if mouth sores are not present. Certainly, if you have any type of irritation to the mouth or throat, staying away from some of those tart foods might be necessary. But if that's not an issue, trying those things to promote saliva production may be helpful. Again, eating soft, moist foods with extra sauces, gravies, or dressings can make eating easier when dry mouth is an issue. You can also try sucking on sugar-free lozenges, mints, candy, or chewing sugar-free gum to promote saliva production and to keep the mouth moist. You can try mouth moisturizers or saliva substitutes. And it's also, again, important to practice good oral hygiene by rinsing your mouth frequently throughout the day with a mild rinse, such as that mix of water, baking soda, and salt. And if trying these strategies don't work, you may want to speak with your medical oncologist or someone else on your healthcare team about other pharmacological interventions that may be available to you. Next slide. I know we're running short on time, so I'm really trying to get through these as fast as I can. So fatigue. Fatigue is that lack of energy, that persistent feeling of tiredness, dizziness, and overall mental fuzziness that can be due to anemia, poor calorie and protein intakes, weight loss, pain medications, cancer treatments, dehydration, or disturbances in your sleep. And it can definitely lead to poor intake, weight loss, even sometimes weight gain, and depression. Next slide. So what can you do for fatigue? So again, I know I've said this so many times throughout the last hour, but eating small, frequent meals and snacks throughout the day where you're having a steady calorie intake can definitely help keep your energy levels up. And choosing nutrient-dense foods and having those high calorie, high protein snacks on hand to snack on often throughout the day is certainly a helpful strategy as well. You know, when you're really physically exhausted, cooking can really seem like a huge hurdle to overcome. So it may be easier to eat, easy to prepare, easy to eat foods on those days, like sandwiches, salads, cereals, yogurt and fruit, cheese and crackers, trail mix, nuts and seeds, so that you're not expending all of your energy just trying to prepare your meals and snacks. Definitely is helpful to eat when your appetite is at its best. You know, if you notice there's times of the day when your appetite and your energy levels are really at their peak, I strongly encourage you to take advantage of those times and try and eat a little bit more to make up for times when you just physically cannot. Definitely try and enlist the help of family, friends, and caregivers to help with grocery shopping and food preparation. Again, so that you're not using up all of your energy on the acts of acquiring and preparing foods. You can really save up your energy for when it's time to eat, to get those calories and other nutrients in. I know that this may be the last thing you want to think about when you're fatigued, but participating in light physical activity and just continuing those daily living activities can also really help keep your energy levels up throughout the day as well. And planning for periods of rest, especially after physical activity and exercise, so that fatigue doesn't start to snowball, is also another effective strategy. Next slide. Okay. Yes, we made it through all of the topics. I thank you all so much for your patience and for hanging in there through all of those topics. What questions do you have for me that we haven't gotten to address throughout these 2 hours?
Anything, anybody? We answered all your questions, huh?
Okay.
I don't see anything in the chat, just a lot of thank yous and whatnot.
Well, I really, again, I appreciate you hanging in there and sticking with us for the full 2 hours. I know it's a lot of information.
It's a lot of
all
information.
in one shot. So I really appreciate it. And I truly hope that this was helpful to you. And if you're able to walk away from this presentation with a few strategies to make eating easier for you to get through treatment, that makes me so happy for you.
Well, thank you so much, everyone. We really enjoyed presenting, and we hope that everyone feels better soon, and hopefully we'll get through this COVID season soon, because we are missing the caregivers in the cancer center, and hopefully everyone can come in safely pretty soon.
Yes. Is it all right with you, Tracy and Dr. Habib, if I share the slides with the people who participated?
Absolutely.
Okay.
Sure, please.
And can I share your, Tracy, I'll share your phone number and your email address. Is that okay?
Yes, please do. If any of you think of any questions or concerns after today's presentation, please don't hesitate to call me or email me at any time.
And Dr. Habib, I can share your appointment line phone number?
Yes, please. Yes,
Okay.
please. Thank you.
Very good. And then I'll also send out a survey. I was going to put it in the chat, but I'll send a survey out separately so that we can get some feedback. And that's it. Thank you, everybody. Thank you, Dr. Habib. Thank you, Tracy. You guys did a great job.
Thank you both. Thanks, Alicia. Thanks, the guys, for being here. And thank you, Tracy. Amazing. I love your presentation. I learned something today. Thank you.
You were the rock star of the show. Thank you so much. You were great.
You are the singer. I'm the lead guitarist. We got this. All right. Take care,
You guys
guys.
are great.
Take care, everyone.
Thank you,
Thanks so
everybody.
much. Bye-bye.